All right. So tonight we start module 4. We have 5 modules total. This is the last fairly large module that we've got. It's not as bad as the medical as that was, but we're getting kind of into the home stretch. Module 5 is only like 3. Module 5 is only like 3 chapters, and then we're done with the lectures. After that, it'll be just 5 days of hands-on training. Then you guys go to the ambulance. So you got a 94. I think you might be the highest. So awesome work. Anyway, yeah, let's get started. Get through the competencies. All right, let me rearrange a couple of things here. We should be fine for not being plugged up. If I just disappear and the class ends, it means my battery died, but we should be good. All right, so for trauma, trauma's a little weird because there's not a lot that we can do, right? Mostly, or at least to fix trauma, there's not a lot that we can do. Let me rephrase that. We are, even at the paramedic level, we're mostly stabilization. Surgery fixes trauma, but trauma can be some of the quickest ways for your patient to die on you, and this a lot of times it's the hardest one to do, even though it's really, you'll find that the process is easy. But when you look at your patient and he looks like something like he stepped out of a horror movie and there's blood everywhere, bones are sticking out, limbs are spinning or bent in ways they shouldn't be, it's easy to freak. So this is the module. This is when you're dealing with this stuff, this is going to be pretty much where you're mostly concerned with not losing your own train of thought and getting tunnel vision. Your job is to stabilize the patient and then get them to the hospital so that they can be taken care of. For people under 44, traumatic injuries are the leading cause of death in the United States. That can be just because of accidental injuries. It could be hold my beer moments. It could be just teenagers not realizing how dangerous some of the things they're doing can be. Proper pre-hospital evaluation and care can reduce suffering, long-term disability, death, and death from trauma. Trauma emergencies occur as a result of physical forces applied to the body. These are not things that happen inside, even though they can either cause some metabolic issues or they can accompany some metabolic issues. Trauma itself is anything that happens to you from an outside source. Whereas medical emergencies are things that kind of happen from inside, right? So we talk about an organ getting inflamed or something of that sort. Traumatic injuries may be caused by an underlying medical condition, or medical illness may result from a recent or remote traumatic injury. So an example of that would be surgeries causing issues with somebody throwing clots, or some heart issues coming out of a certain surgery. Just depends on what was going on. Evaluation of your mechanism of injury for the trauma patient will provide you with an index of suspicion of exactly how bad it might be. An example of that, we're going to do a chapter on burns. Most of the time when we think about burns, we think about somebody just touching a hot surface and then burning their skin. But a burn from an electrical injury, you're probably going to have the burn marks where the electricity made contact. But is that the only damage that they've got? Right? Say somebody grabs a hot line. No, absolutely not, right? So it could be full body, head to toe burns. If they get struck by lightning, for example, that's, if they're not a pile of ashes on the ground, they're going to have, all their systems are going to be affected. There's a lot more to it. That's what we can see on the skin. So your mechanism of injury a lot of times is not just what you can see, it's knowing what happened and what can that cause. That's a good example of where MOI just goes beyond, well, it looks like he had a broken leg. So energy and trauma, traumatic injuries occur when the body's tissues are exposed to energy levels beyond their tolerance. And that can be energy in the form of heat. That can be energy in the form of, say, like inertia, physics hitting you, breaking a bone, messing up a joint, bending it in a way that it's not meant to be bent, or bending it in the right way, but too far. Those can be traumatic injuries. Mechanism of injury is the way the traumatic injury occurs. So 3 concepts of energy. We have potential, kinetic, and energy of work. Energy can be neither created nor destroyed. If you guys remember that from like 6th grade science, right? It can only be converted from one thing to another. So a slingshot pulled back has a lot of potential energy in it. It's not doing anything. You're holding it back, and the more you pull it, the more potential energy there is. When you release it, though, and it pops through and shoots your rock or whatever, that's kinetic energy. That's actually energy in motion being used. It's not. It didn't get created. It was just the potential energy transferred over to it. Work is defined as force acting over a distance. Forces that bend, pull, or compress tissues beyond their inherent limits result in the work that causes injury. All right, so they're going to get into a little bit of math on this. You really don't need to know it. I think we're going to, yep, this is the slide I'm looking at. So kinetic energy equals half the mass times the velocity squared, blah, 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 blah. It's not a math class and it's not a physics class. That just basically, the big thing about this is to understand that if you're talking about, say, a moped hitting a wall, the amount of energy released is not nearly as bad as, say, like a freight train running off of a bridge and into a cliff. That's the big thing here. And then obviously, the faster you're going, the worse it's going. Well, we won't really get into that too much. I'm not going to give you any math problems. Don't worry. So your MOI from falls, or I'm sorry, MOI profiles. We have non-significant, and then we have significant. Non-significant mechanism of injury, that's just injury to an isolated body part. So if somebody sprains an ankle, it's really not that bad. They fall without loss of consciousness or within a certain feet, and they've changed that over the years. It used to be 15 feet, and there was a magic number. Now it's 3 times your height. So if you're a 5-foot person, then 15 feet works for you. I'm 6'2", so a little bit closer to 20 feet would be significant for me, at least by the way that they define it. Significant MOI, this is injury to more than one body system. So multisystem trauma, this can be, you're in a car wreck, you have musculoskeletal injuries, but your organs also took some damage, like your heart slamming into your chest wall. Then you've got a bruised heart, the seat belt hurting your abs. That can cause issues, these kind of things. Falls from heights, motor vehicle and motorcycle crashes, car versus pedestrian. And that can be, they don't have to be on foot. All right, they can be on a bicycle or a motorcycle. Gunshot wounds and stabbings. Let me ask you this, and we'll talk more about this when we get into peds and everything, but if a kid gets hit by a car, where do you think most of the damage will be done? And we've probably already talked about this. The head. All right, let me ask it to you this way. Do you think most of the damage will be anterior or posterior on a child? Front of the body or back of the body?
So it's going to be most of the interior.
Most of the,
in the process of doing that at the moment. We did not have anybody available.
I didn't catch that last part. Anyway, most of the damage to a child, if they're hit by a car, is actually going to be anterior, mostly to the front of the body. Yeah, you're going to have damage to the head, damage to the neck. But as far as like if you're looking for bruises, if you're looking for scrapes and that kind of thing, it's going to be to the front. Reason being, children tend to turn toward things that catch their attention. And I don't know if it's natural curiosity or what, but statistically, if a child walks out in the street and a car is about to and they honk the horn, the child's going to turn toward the car. Adults, a little bit different. We know it's coming. We don't want to see it, basically. So we walk out into the street as an adult. We hear somebody honk their horn, screech their tires. We're going to turn away because I don't want to see this coming. So your adults are going to have a lot more damage to the posterior side, their back, their back of their leg, their buttocks. All that's going to be taking the brunt of it. And again, yes, circumferential damage like to their neck, that sort of thing is going to be there regardless. And I'm just saying, that's not intentionally, but I might have forgot to look both ways before crossing the street a couple times. All right, blunt and penetrating trauma. So as we're going through this, I want you to think about your DCAT BTLS. We've talked about it in the past when we were going over patient assessment. So your deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. Think about what those are and where you're gonna how those are gonna present based on what we're talking about here. So traumatic injuries can be divided into 2 separate categories. We have blunt trauma and penetrating trauma. If the damage does not break the skin, then it's blunt. If the damage is penetrating, like a knife wound or a gunshot, then it's going to be penetrating trauma. Either type may occur from a variety of MOIs. Not everything is involving a weapon, but usually when we're talking about penetrating trauma, a lot of times that's what we tend to think about. It's important to consider unseen as well as visible, obvious injuries with either type of trauma. Just because something didn't break the skin doesn't mean it didn't do damage below. So for blunt trauma results from an object making contact with the body. This can be anything from a baseball bat to a car, falling from a height. Any of these can be blunt trauma. Motor vehicle crashes and falls are the most common. So be alert to skin discoloration and pain. A lot of times that is going to be bleeding that may not be breaking the skin, but could still be happening. And then obviously pain at the site because they got hit. Maintain a high index of suspicion for hidden injuries. The problem with blunt trauma is because it doesn't break the skin. Sometimes we take for granted that there may be injuries. For example, anybody watch football? Drew Brees got flattened the other night, and he's running around. He didn't have any ribs poking out. He didn't have any penetrating injuries, but he wound up with a collapsed lung and a few cracked ribs. The only way for anybody to know for certain that was going on with him was to give him an MRI and an X-ray, which we don't carry in the field. So a lot of times you just have to kind of err on the side of caution and say, hey, you know what? You smack the steering wheel hard enough to break the steering wheel, which is made out of foam covered metal. Imagine what that did to the ribs and everything underneath. So speaking of vehicle crashes, these can be classified in different ways, and they usually are classified based on how the accident happened. So you have frontal, which is a head-on collision, rear ends, lateral, rollovers, and rotations. The principal difference is the direction of the force of the impact. A crash typically consists of 3 collisions. First of all, you have the car against either the other car, the tree, whatever it is that they hit. The damage to the car does not directly affect patient care, but it does provide information about the severity of the collision, especially if they're not buckled up. And I can go on a rant about this because when I was younger, I used to be very much, I don't like to buckle up because the seatbelts do damage. But I realized as I got mainly into my career and a little bit older, the seatbelts are not designed to not hurt you. The seatbelts are designed to hold you in place so that all those safety features that are in the rest of the car, like your airbags, the seatbelt's just designed to hold you in place so all that other engineering can work for you. If you're not buckled up and you go flying over the steering wheel, all those airbags didn't do anything for you. But assess the vehicle. Try to get an early look at it, especially during your scene size up, because you can get an idea of what we're up against based on how bad the car is. So the second is a passenger against the interior of the car. So car hits tree, you hit steering wheel. That's your second impact. Kinetic energy produced by your mass and velocity is converted into the work of stopping your body. If you're driving at 70 miles an hour, even though it doesn't feel like it, you are moving, careening down the highway at 70 miles an hour. If your car comes to a stop, you're still moving at 70 miles an hour until you hit something, either be it your steering wheel, your airbag, your seat belt, the windshield, the next tree past the one your car hit. Something's going to stop you. Common passenger injuries include lower extremity fractures, rib fractures, and head trauma. Depending on how you're fastened, depending on the way that the car gets hit, you may go up and over. Hopefully your airbag protects you that way. I've had patients go down and under their dash where we've actually had to cut the brake pedal loose from the vehicle because it was impaled into their legs. These kind of things. It just depends. Some people sit back. They'll lay back. They'll lay their seat back, and then when they impact something, they just slide underneath their steering wheel, and then they have to deal with getting crunched up under their dash, engine compartment landing on them, any number of things in that way. Some people sit high so that they, typically shorter people will sit higher up when they're driving larger vehicles so that they can see over the hood or whatever. Those patients, especially when they're not buckled up, they tend to go up and over. So you'll find them on top of their dash, through the windshield, on the hood, down the street. Just depends on how bad the accident was and whether or not they were restrained. All right, and then the final hit is your internal organs hitting usually the front of your rib cage on the inside. Internal injuries may not be obvious like external injuries. You know, you show up and you see the broken bone and blood everywhere, but you forget that the heart's just hanging out in a water balloon. Um, so it's going to hit the front of the ribs, and then you're going to have some bruising and swelling there. If they hit their head, then their brain is going to hit the inside of their skull at the front. You're going to have bruising and swelling there, which is a big problem. We're going to have a chapter devoted to that for traumatic brain injuries. But these are the other things you got to think about. It's not just the injuries you can see. Significant mechanisms suggest, or I'm sorry, significant MOIs that can tell you you have a massive, massive problem other than your patient appearing dead. If there's a dead person in the vehicle due to the I'll say due to the accident, so you know you find them in the trunk, that's a different story. But if the passenger is deceased, then the driver and anybody else in the vehicle is going to automatically be a high priority for transport, high significant mechanism of injury. Severe deformity of the vehicle or intrusion. Um, some curriculums will put out there that if there's intrusion of any part of the vehicle more than 12 inches, so more than a foot into the passenger compartment, they're automatically considered a high priority for transport, even if they're out walking around. In fact, if they've got that kind of intrusion, they're walking around, usually you want to try to tell them, hey man, you should probably sit down and don't move. Moderate intrusion from a lateral accident, so if they get hit in the doors, even if it's 6 to 12 inches, then that's significant. Severe damage from the rear. We worry about whiplash, crashes in which rotation is involved, and ejection from the vehicle. Those last two, usually ejection means that they weren't buckled up, but crashes in which a rotation is involved, if they're not buckled up, they're going to have damage from all ends because they're getting thrown around inside of their vehicle. So for frontal crashes, evaluate the supplemental restraint system. Make sure they were buckled up and look and see if the airbag's deployed. What do you guys think is worse, airbag deployment or no airbag deployment? No airbag deployment. That's actually worse. Um, we get caught up on the fact that if they were in a wreck, they should have had the airbags deployed. So if it didn't deploy, maybe the wreck wasn't that bad. But if you're really surveying the scene and you look and you see a crunched up vehicle, you know it was bad. So if there's no airbag deployment, that means that safety feature wasn't there. Um, so if you are taking registry or any test for that matter, and when you get out into the field, pay attention to that. No airbag deployment is that's a significant problem, even if they're buckled up. Because the seatbelt's not designed to be what saves you. The seatbelt is just designed to keep you in the system that is designed to save you. Seatbelts and airbags are effective in preventing a second collision inside the motor vehicle. But again, that's not, like I said, the seatbelt is there to keep you where the airbags can protect you. The airbags are the ones that are meant to really buffer things. Despite airbags, suspect injuries to the extremities resulting from a secondary collision and internal organs resulting from the third collision. If we're dealing with children, if they're shorter than 5'9", they should ride in the rear seat. I'm sorry, 4'9", not 5'9". In a pickup truck or a single-seated vehicle, the airbags should be turned off. Some vehicles have a sensor where if there's not enough weight in the seat, the airbag is not going to turn on. But if your child's, if they're short enough, if they're still using a booster seat or something, you may want to use the key and turn the airbag off in that area. Remember, if the airbag did not inflate during the accident, it may deploy during extrication. So if we're having to deal with that from an accident scene, you may want to do what I like to teach people is to take some webbing and just crisscross it around the steering wheel, tie it off so that if the airbag does deploy, that webbing catches it and it doesn't pop you while you're in there with the patient. All right, for your supplemental restraints, they're going to hurt you. As you can see in the picture, this guy's got what looks like a seatbelt injury across his chest and a couple of burns, some different abrasions on his skin, mostly probably from the airbag system deploying as well. You're in a bad accident. They have to be tough enough to stop you from moving 70 miles an hour through the windshield. You may get some pretty bad skin burns, but you'll live to talk about it. And if you're not buckled up properly, or if the airbags don't deploy properly, then obviously those safety mechanisms didn't work. So you may have to look at a possible worse injury than what would hopefully be there. Look for contact points between the patient and the vehicle as you perform a simple, quick evaluation of the interior. Things you're looking for in the interior are any kinds of damage that may have happened from the wreck. So a bent steering wheel, spiderweb windshield, the seat belts themselves can cause damage. If you look in there and the patient's not buckled up, then that's a whole other slew of issues. Hopefully they are. Some cars now are annoying. When you don't buckle up, I know a couple of Fords will actually shut the radio off. I don't know if anybody's got those cars. Mine just drives me crazy with the dinging. Like I buckle up, and then a buddy of mine, he refuses to do it. I'll actually stop and sit there and stare at him until he buckles up. Just because that ding just drives me insane. Rear-ended crashes. Rear-end impacts cause a whiplash type injury, particularly in the absence of an appropriate placed headset. How many people ride with their headsets all the way down? So, all right, Wesley. So, like the headrest in your car, where do you place yours, or any of you? I'm not calling you out. You just said say again. Do y'all put it where it's lined up with the back of your head, or do you keep it kind of a little bit lower so you can lean your head back over it? I don't want to adjust it really. A lot of people don't. Yeah, it does. It forces it. Too short to line it up. Mine is with my head. All right, good. So they should be placed to where the back crown of your head hits the seat itself, so that if you get hit from behind, your head doesn't whip back over it. It hits that rest quick, and it hopefully keeps you from having that whiplash injury. A lot of people don't do it, but in other countries, yeah, and actually in some other countries like England, they will fine you. They'll write you a ticket if they pull you over for something like, say, speeding, and they look and they see that your headrest isn't lined up. They'll write you a ticket for that too, just because it's a safety issue. It's like getting pulled over and not being buckled up. So, just to talk about whiplash, as the body is propelled forward, the head and neck are left behind. Cervical spine and surrounding area may be injured, and you have the problem with the brain getting whipped around in the skull, which leads to TBIs, and then we have all kinds of other issues that we can't fix in the field. So that's why those are bad. If that's what you're seeing, then usually copious amounts of diesel is what's needed to get your patient to be better off. Lateral crashes. Lateral or side impacts are a very common cause of death associated with motor vehicle crashes. There's just not a lot of protection on the sides of your vehicle. More of them are coming with side airbags, which is great. But if you think about it, if you get hit head on, you've got your entire engine block to buffer out some of that impact. You've got your airbags, your seat belts are designed for front crashes where you're going to go forward. If you get hit from behind and your headrest is in place, then usually you're fine there. You've got the bulk of your vehicle between there to buffer some of that energy, and your safety mechanisms are designed to that direction of travel. But if you get hit from the side, short of a side airbag to protect your head from hitting the windshield or hitting the glass of your door, that's it. You've got like maybe 4 inches of metal between the car that hit you and your seat. So it really doesn't take much to be a bad accident when you get T-boned or otherwise just hitting the corner like that. Your seatbelt's not designed to stop you from moving in that direction. So Usually there's nothing there. All those safety features don't really do anything for you. A vehicle struck from the side is usually struck above its center of gravity. So it'll begin to rock away from the side of the impact. This usually results with you having a lateral whiplash injury. If there's substantial intrusion into the passenger compartment, then you can expect lateral chest and abdomen injuries on the side of the impact. So popped lungs are really common. Your patient's going to be pretty banged up, pretty bad off on that side. Possible fractures of the lower extremities, the pelvis, and the ribs. So major internal bleeding is going to be a concern. And then organ damage from the third collision. Approximately 25% of all severe injuries to the aorta that occur in the motor vehicle crashes are a result of these injuries. Your body's pretty well designed, even without the car's protections. Your body's pretty well designed to take impacts to the front and back. It's just that's what your rib cage is designed for. But because your heart just kind of hangs there, and you have much more room to go side to side than you do forward and back. If you get hit laterally, a lot of times the heart will, that third impact will pull the heart so far over that you wind up shearing your aorta, and then you have the same issue as basically like say an aortic aneurysm, where your patient can bleed out and die in about 6 seconds, and you don't have any time to do anything. Rollover crashes. Large trucks and sport utility vehicles are prone to rollovers because of their high center of gravity. Ambulances used to have this problem, but all ambulances made in the last, I don't know, 20 years or so, have a really heavy skid plate basically at the bottom that lowers the center of gravity. Doesn't do the best job, but it does something. And if you guys work for like AAA or any ambulance that's got those little black tattletale boxes in there, you know exactly how bad of a job those plates really do. It's so easy to tilt the truck that it's you almost have to come to a stop to make your turn. Injuries and rollovers really depend on whether the passenger is restrained. If you're buckled up and you roll, you're usually you're okay. Or at least you're not as bad off as you could be. But if you're unbuckled and you roll the vehicle, you're going to get thrown all over the place. The most unpredictable types of injuries are caused by rollovers because you're getting thrown up, down, left, right. You may wind up in the back seat even though you were the driver. There's no telling. The most common life-threatening event in a rollover is ejection or partial ejection. Worst call I've worked, and I won't go into a war story of how it played out. The worst call I've worked was an unrestrained vehicle rollover with an open sunroof. Patient's lower body was still in the vehicle. Patient's upper body was smeared across about 100 yards, well, maybe like 100 feet of roadway. So that one wasn't a hard call, not as far as what we had to do. It was just hard having to deal with it. Rotational crashes, these are when you get caught in the corner. So think like a head-on collision or like a combination of a head-on and a T-bone. You catch the corner of the car and it spins you. As far as your MOI, this is pretty similar to a rollover because you're getting thrown all over the vehicle. If you're buckled up, it's bad, but it's not that bad. If you're unbuckled, though, it's almost like being inside of a pinball machine. The rotation of the vehicle as it spins provides opportunities for the vehicle to strike objects such as utility poles. Car versus pedestrian. These don't play out very well as far as scenes. Like if you have a weak stomach, these are not going to be good calls for you. They're usually very bloody. The injuries, the musculoskeletal injuries are really severe. So these can be really hard emotionally because of what you're actually seeing in front of you. There can also be serious unseen injuries to underlying body systems that you can't see. You must maintain a high index of suspicion for unseen injuries. You should determine the speed of the vehicle if you can. One way to do that, look at if they hit their brakes and locked up, how long are the skid marks? That's something you can look at. Whether the patient was thrown through the air and at what distance. So look at where the vehicle is stopped at and then see how far ahead of it the patient is. Is the patient under the vehicle? What surface did the patient land on? Usually if it's more roadway or parking lot, concrete, something like that. Obviously now you've got much worse injuries just from them hitting the ground. If it was grass, they're still screwed up, but at least that part of the mechanism may not have been so bad. And then look, like I said, look under the vehicle, see if they were pulled under or if they went over the top. Evaluate the vehicle that struck the patient for structural damage. You're really just trying to see how hard the vehicle hit them. All right, car versus bicycle. Evaluate the MOI in much the same manner as a car versus pedestrian, but keep in mind, usually when your patient is on a bicycle, like a child or something, they're up higher, right? So they're much less likely to get pulled under the vehicle. They're much less likely to get thrown. They're more likely to be put over the top of it, just because the impact may pull their bike down, but with them, their center of gravity is up higher. But evaluate the damage to the car, evaluate damage to the bicycle. If your patient's wearing a helmet, inspect the helmet for damage. They're usually just foam, but if it's bad enough, they'll crack. Presume that the patient has sustained an injury to their spinal cord, or at least their column, until otherwise proven at the hospital. So these guys are going to get the C-collar. They're probably, if they're unconscious, they're probably going to get the full board, just because these kind of injuries probably did damage to their lower spine. And even though I know that we always harp about only give it if they have lower back pain injury or whatever, but if they're unconscious, they're not going to tell you that. So just be prepared for it. Car versus motorcycle. Um, Not all states have helmet laws, so just be aware of that. An uncle in my family by marriage was killed on an interstate in a motorcycle accident because he wasn't wearing his helmet. And it wasn't really even like, it wasn't like he got ran over, but he got run off the road by an 18-wheeler who tried to change lanes and didn't see him. And he just laid the bike down and slid. So he should have only had like some severe road rash, like from the mechanism of injury. That's what he should have had. But because he wasn't wearing a helmet and his head popped the ground when he hit the ground, that killed him on impact. Um, and it really didn't even look like it was going to be that bad of an accident. Leather or abrasion resistant clothing is another option for protection on motorcycle riders. And again, sometimes they wear them, sometimes they don't. I've seen people riding on motorcycles with Daisy Duke shorts on. I've seen people in a set of shorts and flip flops and nothing else, no shirt, no helmet, nothing. So I mean, people will they'll take for granted other drivers because they're confident in their ability to ride their motorcycle, and something bad happens that they weren't expecting. Collisions usually occur against larger vehicles or stationary objects. Um, and it may not even be that they hit anything. Sometimes they just kept getting some loose gravel and they wind up losing control of the bike from there. When assessing the scene of a motorcycle crash, look for deformities to the motorcycle. Um, Side of the most damage, so which side did they lay it down on? Distance of the skid in the road, how fast were they going? Deformity of the stationary object if they hit something, and extent and location of deformity in the helmet. A couple of things. One was a joke, actually. So when I bought my motorcycle a few years back, there was another guy that walked in and he had a mirror, like a motorcycle mirror, and he sets it down on the counter next to the guy where I'm finishing up my paperwork. And the guy looks at it and says, "What's this?" And the rider said, "That's all that's left." um, he was kidding, but we had just had a class on trauma and motorcycle injuries at my fire department. So I'm laughing, but I'm kind of like uncomfortably laughing, like, man, that could be, ooh. The other thing to keep in mind too when you're dealing with their helmets, a lot of your motorcycle helmets now have these breakaways so that if you have a patient that's in a motorcycle accident and you need to maintain their airway, a lot of times, at least for a motorcycle helmet, you can do that without removing the whole helmet. You just lift at the chin, there's a lever, and you can actually lift the face of the mask up. If you don't have to take the mask off, then don't. It's okay. But if you can't do your job with the mask in there or with the helmet on, then yes, remove the helmet. So you have 4 types of impacts for a motorcycle. You have the head-on crash, the angular crash, ejection, and the controlled crash. Your head-on is the same, but keep in mind that they're not strapped in like in a car. So head-on crash, the bike's going to stop. And however fast they were going, they're going to keep going. And they may be, 30, 40, 50 yards away from their motorcycle before they even hit the ground. It just depends. Then they're going to slide from there. Your angular crash, these are just where they get caught in an angle. Motorcycle strikes an object or another vehicle at an angle so that the rider sustains direct crushing injuries to the lower extremities between the object and the motorcycle. They have the ejection where they get thrown, and then the controlled crash. Usually, this is where they see something coming, be it like I said, they may went off road or there's some loose gravel from a construction site. I've had that problem before, where the only thing you can do is you're not going to hit anything, but in order to stop it from being worse, you lay the bike down intentionally. A lot of times people will aim for the edge of the street, try to land in the grass, that kind of thing. Hopefully it works out in their favor. Sometimes it doesn't happen though. All right, for falls, the injury potential of a fall is related to the height from which the patient fell. Like I said, they used to say 15 feet. Here you can see they've moved it to 20, and some places will tell you that it's 3 times the height of the person. So if you see any of that on a test, that's going to be your right answer. They're not going to give you 2 options that are that close together. They're going to be, had to be from the 3rd floor or something like that, which isn't the case. So internal injuries pose the greatest threat to life. The fall itself is not the problem. It's that secondary impact of your organs falling and coming to a quick stop as well. Patients who fall and land on their feet may have less severe internal injuries because their legs may have absorbed much of the injury of the fall. However, we actually call that the Don Juan syndrome, where somebody lands on their feet and that injury or that energy transition goes all the way up their legs to their hips and pops their femurs out of joint at the hip, so they can have severe arterial bleeds from the femoral arteries right there. If they wind up cracking their hips, if their feet are spread and their ball and socket joint rams into the hips, they can have severe bleeding from that. And these are injuries that you're not going to see overtly, like there won't be any blood on the ground. But as we've talked about before, these can be life-threatening bleeds just based on how much blood is held in those bones. So take into account the height of the fall, the type of the surface that they struck. Did they land on grass or did they land on concrete? And the part of the body that hit first, followed by the path of the energy displacement. So we talked about people landing on their feet. What do you think kids normally hit with? Do they hit feet first or somewhere else? Heels, if it's controlled, if they knew they were going to fall, usually they'll land on their heels. But usually that's because they meant to drop. They came out of a swing or they jumped down from a tree. But usually kids actually land on their heads because their heads, they're a little bit heavier. Yeah, mostly little kids. Their head's bigger. It weighs more compared to the rest of the body. So as they're falling, they're going to wind up inverting just because the heavier object, the more massive object falls faster. No bueno stuff. All right, for penetrating injuries, penetrating trauma is the second leading cause of death from trauma in the United States after blunt trauma. Makes sense, right? There's only 2 types. Low energy penetration trauma may be caused by accidentally by impalement or intentionally by a knife, ice pick. What's the weirdest thing I've seen somebody stabbed with? A poker from a fireplace. Thought that was gunshot wounds for the longest time. We just couldn't find the gun, and then the wife admitted that she had taken the poker from the fireplace to her husband, and that's what the holes were. Many times it's difficult to determine entrance and exit wounds from projectiles in a pre-hospital setting. So determine the number of penetrating injuries. If you are expecting gunshot wounds, count them. See how many you can possibly find, or any injuries for that matter. If it's a stabbing, if it's an industrial accident, sometimes those are going to be penetrating injuries, like pieces of rebar, nails, Had a guy I worked with shot himself in the hand with his nail gun while we were building trusses. I've had people shoot themselves in the foot. Combine that information with the important things you already know about the potential pathway of penetrating projectiles, right? So if they got shot in the chest, we're going to be worried about their lungs, their heart. If they got shot in the shoulder, we're still going to worry about those things because the bullet may have ricocheted off the bones, that sort of thing. Knives may have been deliberately moved or around internally. So if somebody got stabbed and they twisted the knife or like wiggled it around, you're going to have injuries kind of spraying out more in a wide range than just that direct path that they would have taken when they put it in. So if you can, especially if you can find it, if the weapon is still there or whatever the object was, try to determine the length that they were stabbed with and add that into your report. In medium and high velocity penetrating trauma, now we're talking about bullets, the path of the projectile may not be easy to predict because you're going to have that one entrance wound. So without an exit wound, you really don't know what direction it took. So always try to find the exit wounds. The path, the bullet may flatten out, could tumble or ricochet around in the body before exiting, if it even exits. So anytime you're talking about terminology here, obviously the path the projectile takes, that's going to be its trajectory. If you can figure that out, great, because you can think about what organs are going to be hit. And then also keep in mind that because bullets spin when they go through, when they hit the body, they're going to create this cavitated area of the body that's bigger around than the bullet itself. The higher the caliber and the speed, the bigger that cavitation is going to be, the more organs are going to be affected. If it fragments, if it's the kind of bullet that will fragment, then now you're going to deal with the additional damage from that. And then, like I said, the bullet speed is another factor. So here's a picture I was talking about for the cavitation. Cavitation results from rapid changes in tissue and the fluid pressure that occurs when with the passage of the projectile. The faster it's moving, the bigger the bullet, the bigger this cavitation is going to be. And all the organs in this area may get affected by this. The relationship between distance and the severity of injuries varies depending on the type of weapon involved. Air resistance, often referred to as drag, slows the projectile, decreasing the depth of penetration and injury of the projectile. The area that is damaged by medium and high velocity projectiles is typically many times larger than the diameter of the projectile itself. So an easy way to explain that, your exit wounds are going to be bigger than your entrance wounds. My signal in my house. Okay, that's fine. If you have connection problems, just catch the recording if you can't get in. The energy available for a bullet to cause damage is more of a function of its speed than its mass. So the faster it's moving, the worse it's going to be. And any information regarding the type of the weapon that was used should be relayed to med control. All right, what time? 42. All right, we'll keep going through blast injuries. Although most commonly associated with military conflict, blast injuries are also seen in civilian practice in mines, shipyards, chemical plants, and association with terrorist attacks. We've had obvious terror attacks in this country over the last few years. People think about 9/11. There's been others since then. We had the 1996 bombing at the Olympics, if y'all remember that. We had the Oklahoma City bombings, and those were just the ones that were successes. There's been a lot that have been foiled that were attempts. So they are real. They do happen. I haven't heard about any lately, but for a while there, they were pretty bad. People who are injured in explosions may be injured by 4 different mechanisms. So this is where you start talking about different types of blast injuries. Get to the right slide. You have the primary blast, which is the blast itself. Damage to the body is caused by the pressure wave generated by the explosion. Your secondary blast injuries are damage to the body from this from flying debris. So let's say it's a hand grenade. The primary blast is the concussive force that comes out. The secondary blast injury is going to be the pieces of the grenade itself that hit you, the shrapnel. And then you have your tertiary blast injuries. This is where the victim is hurled by the force of the explosion against a stationary object. So if you're standing by a wall, then the tertiary injury would be you catching the wall that you hit. And your quaternary or your miscellaneous blast injuries, these are usually burns, respiratory injuries, crush injuries, suffocation, and anything else that goes secondary to the blast itself. Most patients who survive an explosion will have some combination of the 4 types of injuries mentioned, depending on how close they were, how confined of a space they were in. These different things can either be there or they may not be. Okay, we talked about those. All right, so in regard to organs, when we talked about this, when we talked about the internal organs themselves, if it's a hollow organ, it's going to have air in it. Organs that contain air, such as the middle ear, lung, and the GI tract, are most susceptible to the pressure changes. Right, when you get smacked with that pressure wave, those are kind of like balloons, so they're going to get hit. Those have a high risk of rupturing, and then you run into the problem of the fluids contained within them are probably going to leak out, and you're going to have to deal with sepsis. The ear is most sensitive to the blast injuries. That's in bold it's not in bold, but keep that in mind. You may see that on a test. I know I remember a registry question that said that. And that's because the ear opens directly to the outside. The tympanic membrane evolves to detect minor changes in pressure and will rupture at pressures of 5 to 7 pounds per square inch above atmospheric pressure, which is almost nothing. If you think about picking up a 5-pound weight, or if you've ever had to open an emergency door, the doors with the lever, you just press the lever and the door opens up, or the bar or whatever, that's about 5 pounds of pressure. The pressure it takes to operate the mechanism, not the door itself, but just to push the lever, is about 5 pounds. It's almost imperceptible to us unless we have a medical condition that weakens us. So it really doesn't take much pressure at all to pop your tympanic membrane. Pulmonary blast injuries are defined as pulmonary trauma that results from short-range exposure to the detonation of explosives. And we're talking about your lungs at that point. The primary blast is often characterized by a lack of external visible injuries, because you're not talking about the shrapnel or the wall you hit or anything of that sort. We're just talking about the pressure wave. So it's not really going to do anything you can see to the skin, but your hollow organs, your ears, those are going to be impacted from that. One of the biggest issues that we worry about as far as their respiratory tract is going to be pneumothorax, which is air in the chest, and pulmonary edema, because that can come on pretty fast. One of the most concerning pulmonary blast injuries is the arterial air embolism. This is where you get air into your arteries and it gets circulated around in the system. And if you've got a section of your vessels that's got air in it, it pretty much just stops all blood flow past it, because your blood is not able to push past that air pocket to push the blood past it. So everything just kind of stops. This can produce disturbances in vision, changes in behavior, change in a state of consciousness, especially if you're talking about cerebral arteries, and then a variety of other neurologic signs. Solid organs are relatively protected from shock wave injury, but they may be injured by the secondary missiles, shrapnel, and stuff that are hurled at the body. Your biggest concern with your solid organs is going to be blood loss. There will be some fluid, like bile from the liver, that can possibly cause sepsis or necrosis, but the big issue there is going to be internal bleeding. Neurologic injuries and head trauma are the most common causes of death from blast injuries. So subarachnoid and subdural hematomas are often seen. We will talk more about that when we get into TBI, what subarachnoid and subdural hematomas are. Bradycardia and hypotension are common, and extremity injuries, including traumatic amputations, are common. It is not uncommon. Think about it like this. We were fighting a structure fire one night down in Poplarville, and this guy had a propane tank sitting out on his garage, like his carport area. And we got there just in time for that thing to levy and shoot. The whole thing became one giant 3-foot long piece of metal that came flying by one of our other firefighters and almost cut him in half. If he'd have been standing about 2 feet more to his right, it would have caught him midsection, and as fast as it was moving, it would have made 2 of them. when you're dealing with blast injuries, that if that had caught his arm, caught him in the midsection, caught his leg or whatever, it would have easily separated him from that body part. There's videos you can find. I'm not saying look them up, but um, there's videos of industrial accidents in the Navy where the wire, the cables that catch the airplane and slow them down so they don't just ride off the other end of the runway on their aircraft carriers have snapped and then come through and hit personnel standing there, and well, you can imagine what happens from there. Um, if it's a blast, the projectiles are traveling so fast that you're not gonna stop them. Usually, it's the wall behind you or a tree or something like that. They'll go through you and hit something a little bit more dense than we are. All right, we're gonna pause here. Take a 10-minute break. We'll get back at 7 and start up with multi-system trauma. All right. I was informed that the 10-minute break is over. Let's get back to this. We actually don't have that much left tonight, which is good for y'all. These chapters in trauma actually are pretty short. So it works out in your favor. You guys get more study time, earlier nights off, that kind of thing. All right, so multi-system trauma involves more than one body system, hence the name multi-system, right? So we're talking about head and spine, chest and abdomen, chest and multiple extremities. You must alert med control and transport rapidly, and these can be really, really difficult to control because you're going to have, like, it could be a single injury that was big enough to cause respiratory issues, cardiac issues, severe bleeding issues, massive burns. These are the nightmare scenarios that we like to give to people in the boot camps, just to make you have to kind of prioritize what you're doing and really stick to your assessment, because otherwise you're just going to stand there and look at the patient or your evaluator and be just like, what the, WTF, mate, that kind of thing. Your main priority is to ensure your safety. If whatever happened to them is still a present threat, then you have to be careful, probably not go in yet. Or else you could be patient number 2 or number 20 or whatever. So saying active shooters, right? We don't run in to start doing patient care while a shooter's still running around the building shooting people. But your priority is you, your crew, and then the patient. Patient's already hurt. He's not gonna. You can't get more. Well, you can't get more hurt, but you can't get like injured or. It's just not a thing. They're already hurt. You're not. So don't add to the patient load. Determine the need for additional resources and evaluate your MOI. Identify and manage your life threats. And now we're just basically doing an overview of your patient assessment. So your life threats come first. Assess your ABCs, control any bleeding, and there's going to be some cases where you will actually put your bleeding first, and it's mainly for life-threatening hemorrhage. If they lost their leg at the knee and they're bleeding out, what good is having an airway if there's no blood to circulate the oxygen? So sometimes you may have to say, I'm going to control the hemorrhage first, not doing circulation first. You're just fixing the hemorrhage. Then you go through and you do your ABCs. You'll come back to circulation to worry about your pulse and all that stuff, and then move on. You'll see some places call it XABCs, X being external hemorrhage. You will not be dinged in your evaluations if we give you a patient with a hemorrhage. It's entirely up to you. The more real world answer is to control the hemorrhage first and then move into your ABCs. The textbook answer is ABC and your hemorrhages and your C's, but we have brains. It's real people doing your evaluations. If I see you go and control the hemorrhage and then move on to your ABCs, that's perfectly fine. You're not going to get knocked for that. Consider using a tourniquet for controlling your bleeding. Protect the spine and proceed with spinal immobilization if indicated. Transport the patient immediately to the appropriate facility. So we have what's called trauma centers. Now, for a lot of you that are in this class, some of you know the hospitals that I mentioned, some of you may not. So we're going to talk about both the hospitals that fit these classes and also what they mean. For those of you that are familiar with Forest General, that is a level 2 trauma center. Unless another one is either opened up or moved up a rank, the only Mississippi level 1 that I know of is going to be UMC in Jackson. That's Ole Miss's teaching hospital. Level 1 trauma centers have all the surgeons that you need to fix traumatic injuries. You have your neurosurgery, your cardiologist. All of them are there 24 hours. You walk in at 3 o'clock in the morning with a jacked up patient, they're already there. You don't even have to call them in. They're just there. A level 2 has all the capabilities, but they don't keep them there 24/7. I am actually not sure if USA is a level 1 or not. Some of the Alabama students may be able to tell you that one. If anybody reads that, if you're in the class and you know, then pop the answer into the text, please. They're at least a level 2. I know the USA is at least a level 2. Level 2, like I said, they're not, all of the surgeons are not there 24/7, but they're on call 24/7. So they may be home and can just come in if you need them to. That's what Forest General is. So that's why it's important. If you activate a trauma patient, you have to let the hospital know ahead of time, so they have time to get people into the building to take care of them by the time you arrive, hopefully. Level 3 means that they don't, when you get down to like 3 and 4, they don't have those capabilities. Trying to think what the hospital was. There's a hospital kind of close to Memphis that is a real big heart hospital, but as far as trauma levels goes, it's a level 3. They don't have a lot of those specialties here, so they end up helping. So you mute. Um, they usually wind up helping you stabilize if you need help beyond what your capabilities are in the ambulance, and then they move them to either a level 2 or a level 1, and then it goes down from there. The Poplarville Band-Aid Station, I believe, is it's the bottom level. They don't, all they can do is help stabilize, and that's it. They move on. They do have a lot of capabilities that are great outside of trauma, but for trauma itself, they're not really able to do a whole lot. All right. Anyway, in most patients with multisystem trauma, definitive care requires surgical intervention. So we always just basically say surgery fixes trauma. You're not going to fix trauma in the field. You can stabilize, hopefully. If you can't, you need to get to the nearest hospital, then stabilize. But if you can stabilize them en route, then great. Pass up the Poplarville Hospital, go on to Forest General. That's okay. On scene time should be limited to 10 minutes or less. And during your transport, obtain a sample history and complete a secondary assessment. Your secondary assessment being your head to toe. Consider ALS intercept and or air medical transportation. Here's the thing though about ALS intercept. There's not a lot they can do beyond what you do. Trauma is trauma. There's a couple of extra steps that will tell you that you need an ALS intercept, and a lot of times it is something to do with their ABCs being unmanageable. So if they have a popped lung and you're worried about air getting into their chest, usually to fix that requires a needle decompression. You guys can't do that as EMTs, but paramedics can. So that would be an example where you would call a paramedic or some kind of ALS intercept to help you out. TBIs, traumatic brain injuries, which, like I said, we're going to have a whole chapter devoted to that. That's one of those situations where you want to get them a helicopter if you can, because even a paramedic, there's not a lot we can do for TBIs. It's usually just get them to the hospital as quick as you can. The minute you think you're responding to a TBI, even before you get there and verify it, radio out for the helicopter. You can always turn them around if you don't need them, but the faster they get there, the better. I mean, with any luck, they might get there at the same time as you. And that is just that much better for your patient. For your patient assessment, this is the same as anything else. It's just like all your medical assessments. Contains your scene size up, where you do your scene safety. You figure out what you're looking at, your primary assessment for life threats, history taking and vital signs, secondary assessment, and your reassessment. When you're caring for a patient who has experienced a significant MOI and the patient is considered to be in serious or critical condition, you should rapidly perform a physical exam. And the way that I explain this is think about the logistics of it. If you show up to somebody who's unconscious on the ground in a pool of their own blood, you know you don't want to stay and play and get their history and let them continue to lay there on the brink of death if they're not already dead before you decide to put them in the ambulance. All right, so this is where I start getting on my soapbox about how those assessments are lined up. You're going to do your scene size up. You're going to do your primary assessment. The minute you determine that this is a critical patient, your next step should be, I need to get you in my truck and going to the hospital. I can do the rest of it there. But before you move your patient, you have to know what's broken, right? You don't want to try to roll them over and then risk rolling them onto a broken hip because it causes more internal bleeding. So the only thing after the primary that I want you guys to think about doing that is going to always be done on scene, no matter what, is the head to toe. And it's quick. You're not doing, oh, you've got a paper cut, I'm going to fix that or anything. No, you're basically just, you need decap BTLS problems with the head? No, great. All right, what about the neck, the chest, the abdomen? You can do a quick priapism check or, screw it, do it in the truck. That's fine. Do a quick sweep of their legs, make sure their hip's not broken. And you're basically just making note of any injuries that are going to affect you getting your patient onto a board, onto the stretcher, and into the truck. If they have a broken pelvis on the right side, then probably not going to want to roll them on the right side when you go to put the board under them. It's that kind of an assessment. Once you get them in the truck, then you can start to do things that are a little bit more focused because you're en route to the hospital. You've got all that time, however time that is, to look a little bit closer in your assessment, get your vital signs, get your patient history if your patient's alert, or you can have a rider, say somebody like if it's a patient's relative, you can jump in the vehicle with you, ask them on the way to the hospital. Try to do as much of the stuff as you can on the way, rather than just doing it right there at the scene and taking up all that time. Injuries to the head. Uh, Disability and unseen injury to the brain may occur. Bleeding and swelling inside the skull is often life-threatening, and this includes a frequent neurologic exam in your assessment. So make sure you're checking their pupils, looking at their level of consciousness. A lot of times when a head injury starts to get bad, they're going to have anxiety, and the altered LOC will be some of the first things you see. Then you're going to have issues with the eyes, the pupils. You may get some posturing when things get real bad. Hopefully you're at the hospital by the time that happens. And we're going to get into the details of that. But a couple of things that I want to point out here, just in case we don't talk about it that night. The way your blood vessels run inside of your head, your arteries are along the outside of the brain, right? They're closer to the skull. They're above the dura. So if you have an epidural, that is an artery, which means it's under more pressure, which means you're going to lose more blood much faster, that kind of thing. The veins are lower pressure. They're running deeper. They're around the brain, inside the brain, that kind of thing. If you have a subdural bleed, that means it's the veins bleeding, usually low pressure, it takes longer for the blood to come out. The symptoms don't come on as fast. Sometimes they can even take days. So keep that in mind, right? If you have a patient that sustained a head injury and they blacked out, like they're very quickly having problems, the faster the symptoms come on, the worse the problem. If they got hit to the head, they seem okay. They may be okay right then. They may not be. They still need to go get checked, but at least if they are having a slow onset of symptoms, it usually means that if there is an injury, it's venous, the bleeding is slow, they have a little bit more time. The pucker factor won't be so bad in the next 10 minutes, that kind of thing. And it's something cool to keep in mind too, if there is a bleed inside the skull, a lot of times the eyes will look at it. So if you look at your patient and his eyes are tracking up to the upper left, usually that's where the bleed is at. The faster they bleed, the more their eyes are going to start to pull that direction, just because what's happening is all that blood is putting pressure on the optic nerve, and it actually pulls their eyes toward that direction. Injuries to the neck and throat. These are an area of serious concern and deadly injuries, mainly because they affect the airway. The trachea may become torn or swell. If you have any kind of injury that you think is going to cause their trachea to swell up, get a paramedic out there, because a lot of times they're going to need a tube, and since we can't put those in, we need to get them out there. Airway problems may result that could quickly become a serious life threat. Your assessment must include the frequent physical exams looking for DCAP BTLS in the neck region. There's a couple of other injuries too I want you guys to keep in mind. So remember what DCAP BTLS stands for. We have deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. Now, with the exception of tenderness, every bit of that is something to do with the skin or the bones, right? Like that's what we're looking at. We're just looking for any deformities or any problems with the skin. And then tenderness is you press on it, and if they scream in pain, they're tender there. In the neck, there's a couple other things I want you to look for, and that is going to be you have one thing in the front center, you have the sides of the neck, and then along the back. And we'll go over this more when we get to the boot camp. But you're going to look for tracheal deviation. The trachea should be midline, straight down the center of the neck. If it's cocked off to one side, that's a big sign right then, before you even make it to the chest, that they have a popped lung. The sides of their neck, their jugular veins, if they're dilated, which means they're all swollen up, that's a sign that they are having a problem with their blood flow, and it's getting backed up into those jugular veins. So now you've got a heart issue. And then the thing that we look on the back of the neck is called step off. You'll basically just take your fingers and you'll rub down, press on their spine a little bit, not hard, just lightly. and make sure that the cervical spine are still in line with each other. If they got hit weird, or if they caught like a whiplash injury, that sort of thing, um, one of their spinal vertebrae may pop out, and it could be putting pressure on their spinal cord. If that's what you see, don't try to fix it. Just definitely put a collar on them. Be very careful how you maneuver the head when you're doing it. The less movement, the better, and then get them to a hospital. Penetrating injuries may result in an air embolism, and then crushing injuries may cause the cartilage of the upper airway and larynx to fracture. For the chest contains the heart and lungs and the large blood vessels. So injuries there can disrupt their ABCs. This is the area of the chest where you're going to have a lot of primary assessment issues. You're still going to do your DCAT BTLS. And I also want you guys to keep in mind, especially when we're dealing with penetrating injuries, look for a couple of signs here, right? Expose the chest, get the shirt out of the way, and look and see if you see anything that might have punctured a lung. You can actually do that in your primary assessment because you're worried about breathing at that point. So you're not skipping ahead in your assessment to do your secondary. You're just looking for that injury just to see if there's one there that might mess with your patient's ability to breathe. Because again, the faster you find that, you can get ahead of it. That's better. Large vessels of the heart may be torn inside the chest, causing massive unseen bleeding. And when they're bleeding in the chest, or especially if it's below the abdominal wall or below the diaphragm, they could bleed enough to go out on you, and you may not even see any swelling, let alone to drop on the ground. Air may collect between the lung tissue and the chest wall. This is known as pneumothorax. And a penetration or perforation of the integrity of the chest wall is called an open chest wound. So if they got shot, stabbed, something went through of anything, like I said, it could be an industrial accident, it could be a car wreck or whatever. If it's left untreated, shock or death will result. It's imperative that you assess the chest region every 5 minutes. If they have an injury here and they're considered an unstable patient, recheck this area every 5 minutes when you do your vital signs, when you recheck your primary assessment. Don't forget your DCAT BTLS. Get your lung sounds, and then observe for chest rise and fall. It should be equal across both sides. Both sides. For your abdomen, this is where all your other vital organs are. Pretty much just all the stuff that makes your body work. They require a very high amount of blood flow to perform the functions necessary for life. So if you start having blood loss, these organs are not going to want to work right. They usually kick up. They're not as quick to complain as the brain is, but they do still cause a lot of issues when blood loss is a thing. Your GI tract usually is the organ system that goes the longest without blood, that still functions. But that's also like it's because it's your least important for life, right? Of all the things that are in there, you'll die from the other organs not working long before you die from your stomach not working. Solid organs include the liver, spleen, pancreas, and kidneys. Your hollow organs are your stomach, large and small intestines, and your urinary bladder. And then, of course, like we were talking about earlier, depending on that type of organ, you're going to have different problems. Your hollow organs are going to be more issues with sepsis. Your solid organs are going to be more issues with blood loss. When injuries from trauma occur in this region of the body, serious or life-threatening problems can occur. So your solid organs can tear, lacerate, or fracture. This can cause serious bleeding, like I was saying. Hollow organs tend to leak out digestive chemicals and other toxic issues. The patient may eventually develop a life-threatening infection, especially from hollow organs. And the rupture of large blood vessels can cause serious unseen bleeding. So when you're assessing, do your DCAT BTLS. And also, when you assess your abdomen, remember we talk about quadrants, make sure you hit all four and make your notes of what you find in all four. So your abdomen is technically 4 different checks. It's not just the abdomen appeared distended. Don't leave it that broad if you can help it. I mean, if all 4 quadrants are distended or deformed or tender or whatever, then yes, that's fine. But specify that in your report. Say that all 4 quadrants had this, or if it's not, then say, this issue to the left upper, this issue to the right upper, that kind of. That way you can kind of narrow down in their record what organs may be having the issue. The hospital will love you for it. You'll look like a rock star to them if you differentiate that. For transport and destination, call for the ALS and helicopter assistance early to avoid delays in treatment and transport. Time doesn't work. Time's not on your side for these because there's just so little that we can do on the scene. Even paramedics, the only real difference between their assessment and yours is 2 large bore IVs and possibly an advanced airway, and that's about it. There's a couple other interventions they can do, but as far as the assessment is concerned, there's not a lot of difference. Trauma is trauma. That's why a lot of this, if you guys are already EMRs, you know 90% of your trauma assessment already. Survival of critically injured trauma patients is time dependent. The longer they are not in the OR, the less chance they're gonna walk away from it. Limit on-scene time to the minimum amount necessary to correct life-threatening injuries and package the patient. If you can be on scene for less than 10 minutes, great. That's called the Platinum 10. Just, gee whiz, you probably may see that. And then you want to have them from the time they had the accident, which sometimes is not something you can control, but from the moment of the accident to the time they get to the hospital, if you can keep it under an hour, that's your golden hour, and that's our gold standard that we try to meet. Especially like if you're out in a rural area, sometimes it's just not possible, but that's what we aim for. The following criteria will help you identify a critically injured patient. So a dangerous MOI, decreased level of consciousness, and any threats to their airway, breathing, or circulation. Anything to their primary lets you know that they're critical. And again, when we're doing the boot camp and I'm giving you scenarios, they're going to all be critical patients. Just keep that in mind. For your type of transport, sometimes ground's not the best option. If you can get a helicopter out there, sometimes ground is the best option. And sometimes ground's your only option. A lot of times the helicopter can't make it to you. And sometimes that is simply because there's some kind of weather pattern between where they are and where you are. It could be blue skies where, at both of your locations. But if there's something wrong between y'all, they may tell you that they're not able to fly to you. And you just have a ground unit. That's all you got. But they do their best. A lot of times they want to fly, but their hands are tied. The Association of Air Medical Services, or AAMS, and Medevac Foundation, they identify the following criteria for appropriate use of emergency air medical services for trauma patients. So this is actually something that is fairly new. I remember when I was working for AAA, our paramedic carried a card, a little like cheat card that had this information on it. There's an extended period required to access or extricate a remote or trapped patient. You can call a helicopter. If the distance to the nearest trauma center is more than 20 to 25 miles, so all you guys down in Poplarville, in that area, a lot of times the helicopter got called pretty regularly, especially before the Poplarville ER opened up, because Forest General was 45 miles away. So a bad trauma patient was hopefully going to go by air. Patient needs ALS care, and there's no ALS level ground ambulance available, or at least available within a reasonable amount of time. Traffic conditions or hospital availability make it unlikely that the patient will get to a trauma center via ground ambulance. So if there's, if it's Mardi Gras in New Orleans, something of that sort, you may need to get a helicopter there just because the alternating streets, like what's blocked, what's not. If there's a problem with the drawbridge, I know that the drawbridge in Belle Chase a lot of times they'd open it up for barges to go through, and then they would have a problem getting it back down, and it would just stay up. Something like that you're just unforeseen, you're stuck in traffic for a long period of time. Yeah, I don't think they're ever going to fix it. The damn thing will collapse before they fix it. But that's a reason for a helicopter if you can get one there. And it sucks too because Oshner is right across the river. It's right there. Like you could throw a baseball and hit the property from the bridge almost. EMS systems require bringing a patient to the nearest hospital rather than bypassing facilities. If you can not stabilize them, that's the point in that. Sometimes your protocol will tell you to do it anyway, but usually it's if you can stabilize them, you can go ahead and take them to the nearest trauma center. If you can't, then just go to the nearest ER. Your patient doesn't really get a choice in those cases. If there's a mass casualty incident, then yes, bring out a helicopter. That's just another means of transport at that point. Your destination selection. Sorry. We talked about the trauma center levels a little while ago. You have 1 through 4, with 1 being the highest. Do me a favor. Make sure y'all are all muted. Here, I'll take care of it real quick. There we go. All right. Level 1's the biggest. They, like I said, they have everything already there 24/7. You find these in your bigger population, higher population areas. So New York City's got one on almost every street corner. It seems like they don't even really need helicopters, because wherever you're at, you're about a block away from a level 1 trauma center. It provides every aspect of trauma care, no matter what time, and they're always there, even if you don't get a chance to call them ahead of time. So I have to keep muting people. All right, your level 2, they're less population dense areas, but still pretty populated. They still provide initial definitive care. They can do all the surgeries there, but you may have to call them and tell them to bring in the surgeons that you need. Level 3 provides assessment, resuscitation, emergency care, and stabilization. Mostly stabilization. So these guys will help you stabilize your patient and then transfer them to a level 1 or level 2. And then your level 4 facility, these are typically found in remote outlying areas where no higher level of care is available. They provide advanced trauma life support, and then they transfer on. They really don't have any capabilities beyond that of the paramedic. They may have nurses there, but again, your paramedic is going to be almost on the same level as them. The biggest benefit to these is the supplies. The last level 4 trauma center that we stopped at, we didn't get to transfer patient care. We kept them. We just used their stuff because we didn't have enough on the ambulance to take care of the patient. And once we got them stabilized, then we continued our way. Do me a favor, Donna. Unless you wanted to say something, mute yourself. If you're talking, I think your connection may be too bad. I got you muted again. All right, trauma centers are categorized as either adult trauma centers or pediatric trauma centers, but not necessarily both. So New Orleans has a pediatric hospital. I think Alabama has one as well. I'm sure y'all do, but I'm not sure where it's at. Let's see. Don't make the mistake of transporting a pediatric patient to an adult trauma center when a pediatric trauma center is available. So there's really not one in Mississippi to my knowledge. So you guys transferring up there, that's where you'll go. And then if they do need a pediatric trauma center, they can always send them to Children's or something of that sort. Y'all that are in New Orleans, if y'all start transporting, just remember that you do have Children's. So if you're dealing with pediatric trauma, that's where they're going to go. If you were to bring them to West Jeff, for example, because West Jeff used to have a big pediatric portion, they may stabilize them and then send them on, or they may look at you like, what are we supposed to do? And then tell you to leave because they don't have those capabilities anymore. In 2011, the ACS COT and the CDC published an updated field triage decision scheme. This helps you figure out where you're going to send your patients. And this is what it looks like. These criteria are intended to help pre-hospital care providers recognize injured patients who are likely to benefit from transport to a trauma center compared with transport to an emergency department. And this is talking about the nearest emergency department. So this is designed to help you figure out, do you need to stop at the first ER, or can you go ahead and bypass it and go straight to the nearest trauma center? Let me mute you again. All right. And then special considerations when you're dealing with these, especially kids, and it's really hard to do. But remain calm, right? Complete an organized assessment head to toe. Don't forget the back. Correct life-threatening injuries as you see them, and especially in trauma. Every time you reassess, definitely make sure that your life threats are still taken care of. The interventions that you did sometimes may slip, like a tourniquet. As you're moving your patient around, you may accidentally knock the tourniquet loose, and then they start bleeding again. So you want to keep going back and double checking. Make sure everything is still as you left it. Do no harm. That should be number one. And then never hesitate to contact ALS backup or medical control for guidance. When in doubt, let it be somebody else's decision. There's nothing wrong with that. Um, because there's going to be calls you guys go on where it's like you don't even know where to start. The patient looks so jacked up. But that's going to be it for the class tonight. Let me get your pen. Do y'all have any questions? Tonight was mostly about what kind of trauma is out there. The rest of the module, we're going to be getting into how do we handle the different things that we see within them. So we'll have like musculoskeletal injuries, burns. We'll have a class on TBIs, that kind of thing. That's going to be the rest of the module. This one was much more of an overview. Okay, so your code for the night, your pen is going to be BC24T. B is in Bravo. There you go. B is in Bravo. C is in Charlie. Number 24, and then T is in trauma. Any questions? Any concerns or issues again with module 3? Everybody squared away. I haven't gotten a chance to look at all the grades, so if you have any questions at any point, let me know. Appreciate it. All right, y'all have a great night, and I'll see you on Thursday.